Hi everyone, and welcome to another edition of the ABMC Research Mini Reviews. I am not Steve Wesselingh, as you might be able to tell. Steve's just been slightly delayed, so he's handed over the chair duties to me briefly to begin. My name is Pete McDonald. I'm the Head of Media and Communications here at SAHMRI. I also fill in for people who are late for webinar chairing. Without further ado, I think we might just get straight into the program. The theme of this week's review is SAHMRI on leukemia, and our two speakers today are Professor Tim Hughes, who is the head of the precision medicine theme here at SAHMRI and a consultant haematologist at the Royal Adelaide Hospital. He will be discussing chronic myeloid leukemia, which he is very much a specialty in the field of, and the current challenges facing that field. Following him, we'll have Professor Deborah White, who is the head of the cancer program here at SAHMRI. She will be speaking about therapeutic triage and risk stratification in leukemia, and the important role of genomics in that. So without further ado, I'd like to hand over to Professor Tim Hughes. Tim?
Thanks very much, Pete. I will just get my screen up. Okay. Is that full screen? Yep.
Oh, good, good.
Okay. All right. So, yes, I'm head of the precision medicine theme, and you've already heard from a couple of the programs. David Lynn and Paul Thomas have already presented, and I'm sure we'll have Grant Rogers at some stage talking about the microbiome. But today we're going to focus on a couple of the groups from the cancer program. You can see that Deb White heads. So it's been becoming clearer that while genomics has been a fantastic way to determine critical targets for cancer therapy, critical biomarkers, it only gives you one perspective on the complexity of the cancer phenotype and genotype. And increasingly, we're going to be looking at the proteomics and the other omics to really understand fully the variation amongst individual cancers and how we might target them more effectively. And it's because of this that we made an application to the Australian Cancer Research Foundation in 2018 to set up the Centre for Integrated Cancer Systems Biology. And this was an effort that went right across the precinct. As you can see, the chief investigators there. It was coordinated very ably by Tamara. And it was successful at getting $2.5 million, which was also supplemented by the Beat Cancer program. So we were able to purchase three really state-of-the-art pieces of equipment, two mass specs and a CyTOF, which provides a potential for mass cytometry. They do really provide a lot of exciting new potential ways to study not just cancer, but beyond cancer. Clearly, the ACRF would like to say that this is predominantly going to be used for cancer research, but it's also available for other projects as well. So if there are things that you'd like to pursue in the proteomics, glycomics, metabolomics areas, please get in touch with us and we'll put you through to the technical expert that can really show you the potential of this new platform, which is also linked to a centralized bioinformatics core. So my area of interest over the last, 30 years has been chronic myeloid leukemia, which is fascinating because it was the first cancer that was shown to be driven by a single oncogene, and that is BCR-ABL, which is an overactive kinase. And it was also the first cancer that was treated therapeutically with a tyrosine kinase inhibitor. So using a small molecule that competes with ATP, therefore reducing the kinase activity of the particular overactive kinase, and therefore leading to a control of the particular cancer. So Imatinib was the very first tyrosine kinase inhibitor that was used in CML. And we've now had over 30 approved for a whole variety of different cancers. But we learned a lot from the Imatinib experience. And since the development of Imatinib in about 2000, we've had second generation and third generation kinase inhibitors that have had beneficial effects in chronic myeloid leukemia, so that the survival in CML, even in the 90s, was only about 20% 10-year survival. We now see better than 80% 10-year survival. And this is one of the examples of the large randomized study that we're involved in, comparing imatinib, the first generation kinase inhibitor, to nilotinib, which is probably the most potent second generation kinase inhibitor. And what you notice is that while this is dramatically better than what we could achieve before we had TKIs, or tyrosine kinase inhibitors, it's actually no better for nilotinib than for imatinib. And that's because even though nilotinib reduces the number of patients who die of CML, there's a slightly higher rate of patients dying of the toxicity of the nilotinib. So it really cancels out any benefit you get from the more potent drug. So we've had this massive challenge where the more potent the TKI that we've developed has been developed, it doesn't give us any benefit in terms of survival. So we were very keen to get involved in studies of this new drug called Assiminib, which was developed by Novartis and is also a tyrosine kinase inhibitor, but works by a completely different mechanism. It doesn't compete with ATP and therefore reduce kinase activity. It actually binds to a specific myristoyl binding pocket. And because of its specificity, it doesn't have all of those off-target effects that we struggle with all of the conventional TKIs. One of the major challenges we have is pulmonary and cardiovascular toxicity, and we're not seeing that with this new agent. So we have the potential for potency without the accompanying toxicity. And we were pleased to be the lead site on the global phase 1 study of this agent, demonstrating how effective it was and how safe it was in patients who had failed every other kinase inhibitor. We've also been very pleased to be the first centre in the world to lead a study which will be Australia-wide plus New Zealand, using this new therapy, Assiminib, as a frontline therapy rather than using it in patients who have already developed resistance. And we think that's going to be an incredibly effective therapy up front with much better toxicity profile, and I suspect equal potency to the to nilotinib. So I think we will potentially achieve better outcomes and I think even better survival with this agent. That trial is due to start at RAH within the next few weeks. Now I want to finish by briefly discussing the challenge that we have with chronic myeloid leukemia and COVID-19, because we have over 6,000 patients around Australia on kinase inhibitor therapy with CML and over 1 million worldwide. And the vast majority of these patients are on TKI therapy and totally dependent on that therapy for their ongoing disease control. So it's quite a dilemma as to, should we be stopping their therapy temporarily if they are at high risk of getting COVID-19? Should we stop if they do develop COVID-19? So one of the key questions we wanted to ask is whether the kinase inhibitors had a net harm or in fact a net benefit in terms of COVID-19. And there are reasons why it might have a harmful effect. There's clear evidence that they're immunosuppressive. They do induce neutropenia and lymphopenia. And we also observe patients with reactivation of viral hepatitis. So that's a concern. They're also associated with significant pulmonary and cardiovascular toxicity, also a concern. On the other side of the equation, certainly imatinib has been demonstrated to have antiviral activity and also this interesting effect of endothelial stabilization and attenuation of pro-inflammatory cytokine release. So in fact, there are 2 trials going on at the moment using imatinib as a therapy for patients with severe COVID-19. And so that really gives you the sort of picture why we are not sure whether these are good or harmful in that setting. So through the International CML Foundation, we've developed a collaboration with across 20 countries and many hematologists, where we're following over 30,000 CML patients to see what happens when they develop COVID-19. And so far we have data on over 200 of those patients, which represents about 0.7% overall of the patients we're following, which is about what you might expect from this cohort of patients. So far, our mortality is looking, I think maybe where you might expect it, about 14% mortality, and it's very much related to age. So you see here the mortality that we've observed in the younger patients, less than 49, just a 6% mortality, but clearly those over 75, small numbers so far, but a 50% mortality. So we need more data, but I think at this stage, there's not a lot to suggest that, that these drugs are harmful, but perhaps not a lot to suggest that imatinib is particularly beneficial, because most of the patients who have died, in fact, were on imatinib therapy. So At that point, I want to stop and acknowledge my my collaborators at SAHMRI, and particularly the RAH clinicians that are also at SAHMRI, key collaborators on these projects, Sue Branford and the ICMLF, the clinical trial coordinators, and of course CML patients who are critical to all of our studies. So I'll hand back to Pete at that point. Oh, it's not Pete.
Thanks, Tim. It's not Pete, it's Steve here. So sorry I was late, everyone, but thanks for everyone coming on board and for these two research mini reviews. I just want to point out to everyone that if they have questions, can they go to the Q&A button at the bottom of your screen and type in your question, and then I'll relay the question to the speaker. We don't actually have anyone who's done that yet. Hopefully we'll get a few. But Tim, do you want to just comment on where do we go from here? I mean, you've done such a terrific job with CML. Where do we take CML from here? You know, is it likely we'll get better drugs that can potentially cure people in shorter periods of time? Because, you know, you are talking about relatively long periods of time on drugs with side effects.
Yeah. Yeah, I mean, while it looks terrific when we've got over 80% alive at 10 years, most of those patients are on drug. They have the day-to-day toxicity, which really does impact on quality of life. And they also have, in many cases, quite substantial cardiovascular and pulmonary toxicities as well. So we see substantially higher rates of stroke, heart attack, etc. When we're using the more potent drugs. This has been a real challenge. So we are now able to get some patients off drug altogether. And in our cohort of patients in Adelaide, out of our 380 patients, we have about 40% who are actually now off drug and remaining in remission. So we think that we can do a lot better than just committing a patient to lifelong therapy. But we need to understand a lot more about how to actually get a patient into a remission that can be sustained once they come off these drugs.
And just, I was very interested in the other impacts the drugs have, particularly in regard to COVID. That was fascinating. But also those side effects, stroke and cardiovascular disease. Does that tell us anything about those conditions? Are people looking or trying to understand the pathogenesis by the fact that you've got so many people on these drugs that it'd be very, you know, there's an opportunity there to learn about the other conditions, the side effects?
Yeah, I mean, there's been a lot of studies trying to understand why these patients have higher rates of vascular disease. You clearly, with the nilotinib is probably the best example. You do see elevated cholesterol. You see their diabetes becoming worse, or they're going from pre-diabetes to diabetic. So all of those metabolic syndrome type features are advanced with the nilotinib, and it's still not completely clear. It's been rather discouraging when we followed the nilotinib patients over 10 years, even with very what we thought was good intervention with statins and modifications of diet and stopping smoking. We didn't really have an impact on that steady high rate of vascular events. So we need a lot more, I think, cooperation with our cardiac colleagues, and we're certainly working towards that.
Is there any hints why the drugs are doing this?
Well, a lot of them are hitting many other targets. And I think, for instance, ponatinib, which is the worst by far for causing vascular events, is a significant inhibitor of VEGF. And we think that might be a major reason for that. And it's the reason we are so excited about Assiminib, which has such specificity of targeting. We think we'll be able to avoid these vascular toxicities unless they're driven by ABL itself, which is still a possibility.
So there's a question there, Tim. Can you see that question?
No, I can't. I can try and get it.
Would the cardiovascular effects associated with nilotinib similar to
dasatinib? Yeah, that's a good question. It's a bit controversial. The dasatinib studies, for strategic reasons, stopped their follow-up after 5 years, so we don't really have 10-year data. The nilotinib data going out to 10 years is much more solid in terms of providing the evidence for the vascular toxicity. But most studies that have looked at try to compare the two think it's a similar activity in both of those drugs. So we tend to modify dose for both dasatinib and nilotinib in patients who have got high vascular risk profiles.
All right, thanks, Tim, and thanks for a terrific talk. And you know, great work, and the COVID stuff, the global COVID stuff was particularly interesting. Our next speaker is Professor Deb White, also from the SAHMRI Precision Medicine theme and from the cancer program. And Deb's going to talk about therapeutic triage and risk stratification in leukemia, the important role of genomics. So, and Deb's putting up her slides, and so go for it, Deb.
Thanks, Steve. Thanks for the introduction. So I'm going to take a slightly different tack, but still talk about leukemia, but talk about the acute lymphoblastic leukemia, which is what my group is focused on. So for those who don't know, ALL is a cancer of T and B cells, or T and B lymphoid cells, and really intrinsically, obviously linked to the immune system. It is the most common childhood malignancy and the biggest cause of non-traumatic death of children in the Western world. We know that around about 20% of the children who are diagnosed with ALL will die of their disease. For those young children, so those neonates that are diagnosed less than 1 year of age, their survival is significantly poorer. So we see a survival there of less than 40%. In fact, really probably significantly less than 40%. And the survival for adults sits at around 40% even today, taking into consideration all different cohorts. So probably one of the things that's becoming more well known now is that ALL survivors have a lifelong risk of secondary cancers and significant comorbidities. So the disease doesn't end with those kids that we can actually apparently cure. So clearly there is a need to understand more about this disease and to improve patient outcomes. So do we just need to know that it's T and B cells? Is that enough? And I think it's really becoming increasingly clear that it isn't. So cytogenetics have gone some way, and this is what we knew about this disease at the turn of the century. So we went from 2 groups to around about 6 or 7 B-ALL subgroups. So these are the greens, and about the same, about 5 or 6 T subsets. So we started to be able to dissect this disease and understand a little bit about outcome. So through collaborations, through understanding the cytogenetics, and then looking at outcomes on clinical trials, we knew that there were some subtypes that really defined patients who did extremely well and others who defined patients that did extremely poorly. So this sort of gave us the first hint that we really did need to understand ALL subtypes. But really the real problem was that there was a large group of patients that sit somewhere between 25 and 30%, where no defined lesions could be identified using the techniques that were available at the time. What we did know was that these patients were very prone to relapse and to poor outcomes. So what we really needed to do was improve the therapeutic approach, particularly within this cohort, to define their risk, to understand what the problem was and how we could actually change the sort of therapeutic intensity, whether that be up or down in this group, and also look at the new technologies or the new therapies, targeted and immune-based therapies, and to see whether we could impact this group of patients who were doing particularly poorly. So it's really probably borne out best by this graph of this Kaplan Maya curve that we published some years ago now, that basically says very simply that if you have high-risk genomics, it almost doesn't matter what sort of approach we take to treatment, they do really badly. So this is in the setting of not understanding what they are and using a risk-adapted approach. So stepwise increases in chemotherapy doesn't improve the outcomes for these patients with high-risk genomics. The other thing that's really important to take from this, and another area that we're really focusing on, is that this high-risk cohort, only 10% of them could actually be identified using contemporary classifiers. In other words, it really took a patient, and it still does to some extent today, take a patient to relapse before they become high risk. And by that stage, I think the horse has probably bolted. So we need to change risk stratification. We need to understand the targets. And I guess the way that we did that, of course, we were moving into the genomics era. So this is just a slide of our current outreach. We have moved from 2 sites. So this was really a very small research project at 2 sites. It's now, over the course of the last 5 years, working with greater than 40 recruitment sites across Australia and New Zealand, sorry, and really joined in national consortia and international consortia to move this work forward and to harmonise data sets. So we take a really multidisciplinary approach to this, very much linked to the clinicians and their patients. So this remains a research tool, but the patients are consented by the clinicians. The samples come to us, we use the sorter or analyzer to actually understand the phenotype of the cells we're dealing with, to select the blast population. And we can really, within a couple of hours of receiving the sample, look at drug sensitivity, whether that be to tyrosine kinase inhibitors, as Tim spoke about, or whether it be to other drugs, so that we can define what a patient may respond to. Our go-to is whole transcriptome sequencing, but we do occasional exome and whole genome sequencing, and we use PCR-based techniques to look for deletions. Without the bioinformaticians, none of this would make any sense at all. So we have a great team of bioinformaticians who put this data together so that we can understand this. And we importantly run weekly molecular tumour boards, which include clinicians, often the referring clinicians, but others from around Australia, bioinformaticians, and all of the research and clinical trial staff, to really assemble the story on each patient. We then develop research reports and perform various follow-up analyses and future research, as I'll explain to you. So this is a really comprehensive program that brings a lot of people into the fold to understand what's going on. But I think that really importantly, it does show that that multidisciplinary approach is important, but actually bringing clinicians really close into this field has allowed us to build this significantly. So what have we done? We've done greater than 600 samples to date, and you may look at this and say, well, all you've done is complicate the story, and pretty much that's true, but I'll pare it back for you a little bit in a second. So this is only looking at B-cell ALLs, and it's only looking at one cohort. This is the age of 0 to 21. So you can see that we've gone from about 6 or 7 subtypes here to 25. And within each one of those subtypes, there are multiple classes, so multiple different fusions. So it looks like a complicated story, but really it is a complicated story. This is a complicated disease. But I think importantly, from a clinical sense, if we look at this as far as what we've achieved, we can see, if we look at the yellow, we've achieved a group of patients that we can now very clearly define the risk stratification and very clearly provide therapeutic options. If we look at the green colouring there, again, these are now groups of patients that we can assign risk to, so we can say whether they're high or low risk. And we and others are involved in ongoing investigation of the therapeutic options. So in truth, for all the complexity and what looks like a minefield, we actually have now probably had an impact for approximately 90% of these patients within this cohort. So this is real clinical impact from a next generation sequencing project. For further research, this is really carried out by postdocs and students, and this is a spin-off from this data. So we look at drug resistance and sensitivity, and this is both in vitro and in vivo. This is to explore new lesions that are identified, and there are many identified through the project, to look at new or repurposed drugs, and really to look at the effect of new immune therapies. From functional impact, so a new lesion, does it actually have an impact? So we use CRISPR-Cas and a variety of other knockout, knock-in approaches to make sure that the sort of thing we're looking at targeting, or the genes that we're looking at targeting, are actually really important and drive the disease. So from the immune effects, clearly this is an important interaction, and we do detailed immunophenotyping, which is currently done on the flow, but hopefully in time we'll be able to move this onto the cytoph, as Tim mentioned, and look at this as a monitoring tool. We also look at cytokine levels. And more recently, over the last couple of years, we've just developed strong collaborations with David Lin and Geraint Rogers, both from SAHMRI, looking at the systemic interactions and the role of the gut microbiota, knowing that the immune system and the microbiome are very intrinsically linked. And clearly some evidence has shown that the late effects are significant in ALL patients. So we're really interrogating what's causing that, what the effect is on therapy, and what the impact of therapy is on the gut. So a really, I guess, systemic approach to looking at improving outcomes in ALL. Clearly genomics and to some extent metagenomics are our go-to, primarily genomics and transcriptomics. But now also exploring this in a much broader way to ask questions about what ALL does and what anti-cancer therapy do to the gut microbiota, to the immune system, and also then asking questions about what changes to the gut microbiota do to patients' response and their long-term outcomes from this disease. So this is I guess, a modifiable area. So we understand the genomics, we're building the repertoire of immune responses, and also now building the changes or understanding the changes that occur in the gut over the course of treatment so that we can modify this. And it may just be an FMT transplant, for example, that may help some patients respond better. So many people to thank, primarily our funders. I have an amazing team who work ridiculous hours on this project. I think our collaborators across the precision medicine theme, our bioinformaticians and the genomics staff, and our clinical trial and logistics coordinators who without whom we wouldn't get the samples here. And our students have done an amazing job at really driving our understanding of these fusions. Thank you.
Thanks, Deb. Great story. Fantastic. Again, just remind the audience that if you have questions, please type them into the Q&A, which is at the bottom of your screen. And we do have a question. What about probiotics? These are being used pretty frequently by people for regular immune and digestive support. Is that kind of supplement impart any protective effect in cancer?
Probably a better question answered by you, Steve, than me. But I think there's probably little evidence that there is any, well, as far as I know, that there is any impact on progression of cancer or in a protective effect. Whether they have any modulating effect or help the gut through chemotherapy, etc., I don't really have any idea. But I think we're looking more understand like an FMT type transplantation scenario where we're actually really changing the gut microbiota over time. So they might make you feel better, but whether they actually have any impact on cancer, I think the jury is probably out. Well, it's probably in, and I doubt if they have any effect at all.
Yeah, so I mean, just as a quick comment, a lot of probiotics get destroyed in the gut because of the high acid level in the gut. So I think we'd probably be looking at some sort of changing the microbiome, either a protected capsule that gets all the way down to the lower gut and colon, or as you said, with a fecal transplant, or some sort of synthetic fecal transplant, which would be even better. The trouble with fecal transplants is the risk in immunosuppressed patients of giving them other pathogens. So something synthetic, and synthetic biology is certainly taking us there, would be quite interesting. Deb, so we do have another, I know we have a thank you, so it's not a question, but a thank you. But Deb, just looking at your diagrams where you bring together the genomics, potentially the metagenomics, the type of cancer, the patient, the clinician input, and almost certainly all of the trials that have happened all over the world. You know, does AI have a place to bring that all together and give some sort of evidence support?
I think that's kind of the space we're going. It's been an intriguing field. I mean, obviously, as you're aware, a lot of the genomic analysis was first started in the US, and actually the EU has been very reticent to jump on that bandwagon. They've done what I call the most complex assays ever not to do genomics. But I think what they're moving into that field now. So across the globe, we are starting to develop a significant body of data, and in fact most of us are sequencing very similar, which is absolutely critical in this sort of field to bring the data together. So I think we're now at a stage where we're getting enough clinical information. We have the clinical teams on board to provide that information. There are two main collaboratives. One is called SAHMRI, which we're involved with the EU. This is sort of being run by Anthony Morman out of the UK, and obviously with Charles's group, where the data is being brought together in large repositories. And certainly through those processes, they're talking about the use of AI to bring, not necessarily the genomics data together or analyze that, but to bring the whole system together.
So I think it's going to be very exciting, and really that is the future of cancer medicine. All right, there's no more questions there, and we're exactly on 5 o'clock, so I might draw it to a close there and thank both Tim and Deb for fantastic talks, fantastic work over a long period of time on leukemias, and really have positioned South Australia at the forefront of this work both nationally and internationally. So thank you very much, and terrific talks. And thanks everyone for joining us today.